to NatRevMD, a podcast where we share tips on optimizing medical billing and improving practice efficiency so you can have the business of your dreams. I'm your host, Dr. Heather Signorelli, founder of NatRevMD. Let's get started. Welcome back to this week's episode. So we have had a lot of questions come up regarding how to bill for transitional care management, or TCM, and really how it differs between, say, a subspecialist and a primary care physician. So this week's episode is going to be dedicated to this topic. And so whether or not you are a primary care provider or a subspecialist, this episode is going to help you understand when to use CPT codes 99495 and 99496. We're going to talk about the requirements for billing these codes and real-world clinical examples to guide you. By the end of this episode, you will walk away with, first, a clear understanding of when to use these CPT codes. We're going to talk a little bit about step-by-step billing requirements, including timing and documentation. And it's always nice to have some clinical examples, so I'll throw a few of those kind of simple clinical examples. And last, we'll summarize top 5 takeaways for you to understand how to avoid common billing mistakes and truly maximize reimbursement when it comes to this type of work. So let's start off with what is transitional care management, right? TCM. So by definition, this is a Medicare service, and it is clinically aimed to ensure that patients have proper follow-up care for after they leave the hospital, right? After they're discharged. And the whole goal of TCM is to reduce hospital readmissions. You're trying to improve patient outcomes, ensure continuity of care, bridging that gap between a hospital-based, care and outpatient care. Really all good reasons, right, to provide this type of service. But the trick is being able to comply with some very specific timing rules so that you can actually get paid for it. So today we're specifically talking about Medicare guidelines, but many commercial payers do follow similar rules. But it's important to recognize that we got to make sure that you understand commercial payer requirements. If you do have certain heavy commercial payers, you may want to look up their policy and be able to evaluate how they manage this. So what is TCM in the sense of what you're trying to do when you see these patients? So obviously, patients experience a lot of complications when they leave the hospital, right? They can have confusion around what medications they should be taking. They could have unaddressed concerns or even new concerns crop up. And so without proper follow-up, we all know that patients may deteriorate, right? They may lead to unnecessary readmissions or even worsening healthcare conditions. So TCM's a service that was developed to try and promote transitional care so that these patients have better options around post-discharge follow-up. Obviously, many of this is already happening from our primary care physicians or even our subspecialists. And this is just another more specific way to get paid for it and reward the work that you're already doing and make sure that that outpatient care is seamless and that there is somebody dedicated and assigned to figure out how to transition these patients effectively and have high touch points when it comes to managing either their acute issues, their medications, their therapy, or coordinating other subspecialist visits. So first, we're going to talk about the eligible settings where TCM can be applicable. And this is important to understand because it's not applicable to every type of scenario where a patient is being seen somewhere. So TCM is specific for patients discharged from the following settings. So inpatient hospital stays, that can be acute care or even psychiatric. Observation status does count. So patients who are under observation but not formally admitted does count for TCM. Skilled nursing facilities counts and inpatient rehab facilities count. Now, places where it does not count are locations like the ER. So if a patient is seen in the ER and discharged from the ER and never has an inpatient or an observation admission, then TCM would not qualify. Another really important thing is that TCM cannot be billed if another physician is already doing it. So if a PCP assumes responsibility, the subspecialist then wouldn't coordinate that care. So you want to have coordination on your end if you are planning to bill for this and make sure nobody else is. Obviously, hospice care patients aren't going to qualify for TCM because that care transition is actually billed under a different set of CPT codes. So let's talk about some of the important requirements when it comes to thinking about these two billing codes. So again, those two billing codes are 99495 and 99496. The first CPT code, 99495, applies to patients requiring moderate complexity medical decision-making. So that first face-to-face visit for this CPT code is going to need to be within 14 calendar days following the date of discharge. Now, you still must communicate with that patient or a caregiver within 2 business days, so 48 hours of discharge. And that needs to include a review of the discharge summary, medications, coordination of care services, potentially referrals and diagnostic tests. So all of that is happening. So again, must communicate with the patient within 48 hours, must see that patient face-to-face within 14 calendar days. And so that is important to distinguish for that 99495. Now, the second CPT code is 99496, is for patients needing high complexity medical decision-making. And that first face-to-face visit must actually be within 7 calendar days of discharge. So different than the 99495. Now, similar to 99495, you still need to communicate with that patient or a caregiver within 2 business days. And obviously, you're going to be doing a detailed review of the discharge summary, high-risk medications, and of course, helping support coordination of complex services. So let's go over these key components again. So that initial contact is within 2 business days. So I apologize. It is not 48 hours of discharge. It is 2 business days. So clarify that 2 business days does count. Now, this contact can be made by phone, email, or in person and should address the current health status of the patient, understanding discharge instructions, medication adherence, and really any immediate concerns. Now, you can have a situation where you attempt to contact the patient, but it's unsuccessful. You just need to document this. And again, as long as you still follow up with that face-to-face visit in either that 7 or 14-day windows, you're not going to be counted against that. But you do have to document that you tried to contact the patient. So you've communicated with the patient 2 business days, then you've set up a face-to-face visit, and that must be within that 7 calendar days for a high complexity patient or 14 calendar days for a moderately complex patient. So again, high complexity is at 99496, moderate complexity is at 99495. Now, this visit is where you're going to include a review of the discharge summary, medication reconciliation, pending test results, coordination of additional services, referrals, home health services, all the fun. And really important that you have a pretty thorough documentation of what you've done. Obviously, if any new issues come up, you're going to want to document those as well. Obviously, documenting any, changes to treatment plans, ongoing patient concerns, all the things that you would normally document in a clinical care scenario, you're going to want to do. So I have a huge favor. If you like this podcast or if it's taught you something, please make sure to share it with a friend, or even better, leave us a review anywhere you are listening to this podcast. It helps us reach more patients or reach more physicians and healthcare team members like yourself. All right, now let's get back and talk a little bit about medical decision-making. So MDM. So medical decision-making really refers to the difficulty of establishing a diagnosis or selecting a care management option. And so this is going to, things to think about is this is going to be, number of possible diagnoses, amount of care management that you're having to do, the complexity of the medical records and the diagnostic tests, and risk of certain significant complications, morbidity, mortality, as well as comorbidities that the patients may have. And so that's going to be what helps decide whether or not this needs to be moderate or highly complex. And obviously the reimbursement is going to be different depending on these 2 codes. So sometimes, moderately complex reimbursements kind of around $200 national average, whereas high complex is, closer to $275 reimbursement. So a little bit of a difference there in terms of reimbursement. And obviously, as we already discussed, that difference between when you see the patient before that face-to-face visit. All right, so let's go over a few real-world examples. First, let's explore where TCM can be billed. And then, we'll talk about a few scenarios where it can't. And again, this is high level, but it should be able to help kind of gauge some understanding around this. So let's talk a first case where we have a 70-year-old patient with diabetes and hypertension who is discharged after a hospitalization for pneumonia. Primary care physician contacts the patient within 2 business days, and the patient is seen within 14 days of their discharge. And things that were done while the patient was seen is you're looking at medication reconciliation, lab reviews, and coordination, potentially with a pulmonologist. So in that circumstance, a 99495 would be billed and the MDM would be moderately complex. Now you have a second case where an 82-year-old patient is discharged from a skilled nursing facility after hip replacement. Now, due to high-risk medications, along with physical therapy needs, the primary care physician actually sees this patient within 7 days, and they had medication reconciliation. They're also coordinating care with the physical therapist, and therefore they billed a 99496. Now, another example is a 65-year-old patient who's discharged following a heart failure exacerbation. In this circumstance, the cardiologist is the one who was coordinating and taking responsibility of seeing that patient post-discharge, and they were the one coordinating all of the care. And so it's important to make sure that that cardiologist is coordinating with the PCP, making sure that the PCP is not also doing those same activities and billing for it. Because again, only one of you can bill for it. That cardiologist sees the patient within 2 business days, reviews the discharge summary, adjusts diuretics, heart failure medications, and they see them face-to-face within 7 days. So therefore, they billed the 99496. All right, let's shift gears a little bit and talk about 2 cases where TCM couldn't be billed. So say a cardiologist was following up on a patient with AFib who had other multiple comorbidities, and that patient was, discharged from the hospital. But in this circumstance, the primary care physician is overseeing the overall transition of care. Now, the cardiologist sees the patient for AFib, but they should be billing an E&M code instead of TCM because they were not actively overseeing that transition of care. Now, another example is a patient was treated and discharged from the ER without being admitted. So they weren't in observed status or anything, and therefore the TCM could not be billed. So hopefully that kind of explains high level what it is in terms of billing and the codes and the requirements for billing these 2. So let's talk next about our top 5 takeaways. First, timing is essential. Physicians must contact the patient within 2 business days of discharge. And again, that can be by phone, whatever, in order to check in on the patient. And again, if you are unable to contact the patient or get in touch with them, just document that and it's still it's not going to be counted against you. And if you do plan to do this, obviously you're going to want to conduct that face-to-face visit within 7 days for the 99496, again, that high complexity, or 14 days for the 99495. Obviously, comprehensive documentation is going to be really important for this. So you're really going to want to make sure that you've documented when you've spoken with the patient, you've documented what you talked about. You're going to document, obviously, the visit, that face-to-face visit, which is really going to need to include medication reconciliation, a review of the discharge summary, important to include that as well, and coordination of any additional care needs that you provided. It's also important to recognize that if a patient is actually readmitted before the required face-to-face visit is conducted, then you cannot bill for those TCM visits. You have to have that face-to-face visit in order to bill for these codes. So really important to understand that if they are admitted, and again, you haven't seen the patient face-to-face, you can't bill for it. Now, if that patient is readmitted after the face-to-face visit has taken, you can still bill for it. So you'll want to make sure that you are documenting seeing the patient, and that is all done before they are readmitted. Of course, making sure that no other TCM services have been provided within 30 days of the original discharge date is going to be another thing to understand and make sure that you are aware of, because that can lead to denials. Obviously, medical decision-making complexity is going to matter, right? So more complex patients use that 99496. For moderately complex patients, use that 99495. And last, only one physician can bill TCM per patient. Multiple physicians are involved. The one assuming primary care responsibility is going to be the one who is managing that transition of care and actually billing for it. Document. I always say that. Really want to make sure that that is obviously a key part of both, your clinic work, transition care management, and that is going to be a key part to getting paid for these claims. So we all recognize the importance of transitional care management when it comes to improving patient outcomes. We all know that when done right, this can prevent hospital readmissions. And of course, knowing all of these rules isn't the sexiest part of our job, but super important to make sure that you know these things so that you can get paid for them and so you can decrease any sort of denials. And of course, avoid audits because no one likes those. And last, did you guys know that we actually do have a medical billing course? So if you are an owner or running an office or just trying to understand more when it comes to medical billing, head on over to our website, NatRevMD.com. That's NatRevMD. and head over to resources and billing course, where you can find the link to sign up on school. Now, we are adding a HIPAA course for you, your staff, and anybody that you oversee. And that will be available as a single buy, course. So you don't have to do the monthly subscription. You can just buy the HIPAA course. And it is something that you can also get a certification that you've completed the course for as well. So the course is really helpful. It talks about all the things to help your front desk improve their collections, has policies, procedures, all the things that may be helpful for your office. All right. Thanks so much for listening. Talk to you next time.